So, welcome back, fourth time, and this part basically which we have done for the regulatory body to convince that this phages can be given parenterally by intramuscular injection, by IV injection, intraperitoneal injection, or anywhere. And for this, we have taken the mice septicemia model, and this study has been basically expanded over the period of 18 years, and there are three, four, five papers which have come out of this on the animal models. And here we have just created the septicemia against different bacteria like Pseudomonas aeruginosa, Acinetobacter baumannii, and Klebsiella pneumoniae. They are the part of the escape organism which are are notoriously known for their drug resistance. They are usually pan drug resistance. Many of the patients who are admitted to ICU, and then they are having the infection with the bacteria which is not sensitive to even a single antibiotic available. And then you just see watching the patient is dying in the ICU because of the septicemia. So for that we are working, and there are certain studies which has been done in 2017. It has been published. But for your information, we started this work in 2005 itself. So I'm showing some of the findings, some of the things, and it may be a bit longer. Maybe it is crossing the 20 minutes, but you bear with us. So this is the story of the one person who, Tom Patterson, who was visiting they're the American citizens, uh, Egypt during holidays, and he developed suddenly food poisoning like symptoms, and his wife was basically medical psychologist or something like that will be coming out, and she's telling that my husband sneezed my hand to say he wanted to live, then squeezed, and then I found a way to save him. She is telling about this, and let us see what was the story. The name of that lady was Stephanie Stardy, an infectious disease epidemiologist, knew her husband, Tom Patterson, was desperately ill. He was at that moment lying in a medically induced coma, but it still came as a shock to hear that he was now expected to die because the infection was because due to Acinetobacter baumannii, which was resistant to almost all the available antibiotics. So this Stephanie decided to flew her back to US where bacteriophage therapy could have been given, and let us see what has happened. So doctors were quickly running out of way to keep the Tom alive as deadly superbug rampaged through his bloodstream, resistant to all antibiotics they had to offer. He is the patient. He is about 6 feet 4 inches tall person, non-medical person, and is suffering from the Acinetobacter baumannii septicemia, which he acquired in the Egypt. The doctor said this is the worst infection on the planet. Stephanie's next step was to approach the Food and Drug Administration with the help of one of the Tom's physician, Dr. Chip Scully of University of California, San Diego, Department of Medicine, which approved an experimental treatment on the compassionate ground. And fortunately, I had also been in one of the research lab of San Diego, and this work was done there only. In 2005, I was there, 2004. And this is the scenario when the treatment was given with the bacteriophages which are available to the military hospital of the American Army, and then it was given to him at several doses, low doses, and he survived. And then this paper was published in Antimicrobial Agents and Chemotherapy in 2017, and it was cited more than 600 times now. So before that, we had already started working. However, the author suggested that many questions remain about the clinical potential of bacteriophage therapy for serious MDR organism. Future studies should focus on delineating and optimizing safety. Safety is very important. Then pharmacokinetics, then pharmacodynamics when the phages are getting eliminated, how long they are staying there, and where they are reaching. Multiplicity of the infection. What dose should be given at particular different situation of the infection, efficiency of bacteriophages, identification and development, and mode of administration, which route you have to apply, and methodologies for monitoring the emergence of bacteriophage resistance once therapy is initiated. So you can see this multiplicity of the infection and valency and efficiency of bacteriophages are very important. And then optimizing safety. I shall be telling you that what we found in coming slides. So in addition, the impact of phage on biofilm and on the microbiome of the host is of interest, as is how best to manage concomitant antimicrobial therapy. So this fellow was having basically the lung infection due to the Acinetobacter baumannii. The primary focus was lung and biofilm formation was there. So it was only bacteriophages which could cure him, otherwise he was going to die. So let us see. They suggested that the novel approach is required, and before that, we need to have clinical trials focusing on delineating the extent to which bacteriophage-based therapy could be used on their own as last resort or as an adjunct to the traditional antibiotic. So we just wanted to see one aspect, that the what is happening if we are injecting the bacteriophages and are there neutralizing antibodies are formed. So we conducted one study in the rabbit model, and we found that neutralizing antibodies are appearing only after 21 days of the administration of the bacteriophages intramuscularly. So if in acute infections, so the neutralizing antibody are not the important factor. So this is very encouraging. The second study we did, that we gave the oral bacteriophage therapy in Charles Foster rats just to see that what are the immunological response and adverse effect, and we found that oral administration was having almost no adverse effect in the rat model. Then we published one paper, and this was on the bacteriophage therapy against Pseudomonas aeruginosa septicemia. And the finding at that time was there, it was the initial study we did, that we gave the very high dosage of the bacteriophages, 10 power 12, thinking that bacteriophage will go and kill the bacteria and then the mice will be saved. But you see, we were wrong at that time, because optimization of the doses are very important. So what we found, that when we give the high doses at the early hours of the infection, that is before 6 hours and after 6 hours of the exposure to the bacteria, there were too many deaths. About 40 to 60% of the mice died. And then the same dose 10 power 12, when given 24 hours after the bacterial challenge, they survived. So it was very surprising to us that the bacteriophages as such should prevent the death and kill the bacteria. But later on we found that if the bacterial lysis is occurring suddenly, this may lead to one problem, that sudden lysis may lead to the endotoxin release in huge amount, and that the patient or the host may not combat, and this endotoxemia may lead to the shock and death. So then what to do? What to do? So we found that there must be optimization of the doses. So later on, in this case only, we reduced the dose from 10 power 12 and came down to 10 power 9, and then the volume of the dose was also reduced, so we found some protection. But still it was, we were not sure that if it is protective at after 24 hours, why it is not protective at 6 hours. So we took another study. I'm not going to the detail of these graphs. I shall be showing you uh, some of the videos later on, and you can see that if the in group 1 there was death, that is 6 hours before and 6 hours later, these two, group 1 and group 2, but after 12 hours simultaneous and 24 hours, there was no death. When we reduced the dose of the bacteriophages, again you can see this was the original one. After 6 hours there was death, but when we reduced the doses volume, say from 100 microliter to, we came down to 60, 40 and 20, and then there was protection. So this paper was published in Indian Journal of Medical Research in 2021 on the Acinetobacter baumannii. And then in this case, what we found, that when we came down 10 power 9, because 10 power 9 was preventing the death in the case of Pseudomonas aeruginosa, here we found that when we were giving the 10 power 9 dose, there was some mortality after 12 hours and 24 hours. But there was no mortality in case of 6 hour either way, either side of the injection. So again we found that probably the doses should further be reduced. So we just did that one, and 10 power 9 was again giving the death. So we reduced it and we found that it was the 10 power 5 PFU per ml after 24 hours, which was preventing the death. This was effective at the early stage of the infection, that is after 6 hours of the challenge of the bacteria, and also after 24 hours after. So this is the picture, and then we were not sure that whether it is 10 power 5 will be effective at the early stage of the infection, means simultaneously we are injecting the pseudomonas, because prophylactic doses are important in the therapeutic practice. So if you give the bacteria side by side, you are giving the phages, they are not causing any death in either of the situation, whether high dose or low dose is there. But in certain cases, the higher doses of the bacteriophages are causing the death, and the cause of the death was because the bacteriophages are basically lysing the bacterial cell, and cell wall is broken down. The endotoxin basically lies in the gram-negative bacterial cell wall, so the huge amount of the endotoxins are produced. So one of the journal of the anesthesiology maintains that the as far as possible, if patient is in stage of septicemia where are just circulating in the blood, the antibiotics which are acting on the cell wall like penicillin, cephalosporins and monobactams should not be given, because they are lysing the bacteria and cell wall endotoxins are coming out, and patient may die because of the endotoxin, not because of the bacterial infection as such. So that was the suggestion. That's why we tried to have the several doses and safe doses in any situation or any severity of the bacteremia. So we carried out another um, experiment on Klebsiella pneumoniae. This was funded by Department of Environmental Sciences under the NMCG Namami Gange project, and we could complete in 2 years. The findings were very excellent, and now we are confident that we can convince the regulatory bodies that you please permit us, and these are the safe doses. And we found here, I'm not going to the complication of this one, if you reduce the doses 10 power 4, 10 power 3 and 10 power 2, then it is not going to save the mice, challenged mice, in any of the condition. But if you increase the number of doses, say 10 power 12, in the early stage of the infection, the mice were dying because of the sudden lysis. That is called as Jones phenomena. Optimum number of the bacteria and optimum amount of bacteriophages may lead to the sudden lysis of the bacteria, and that may lead to the overload of the endotoxin. But if you are giving the small doses of the cocktail of the bacteriophages, and maybe you are giving the repeated doses, as was done in case of the that person from the US, and then you monitor the vitals of the patient, so probably there will be no death. And we could found that this is the 10 power 5 PFU per mouse. It can be given safely after 24 hours of the bacterial challenge, or it can also be given safely simultaneously or 6 hours after the bacterial challenge. And then we estimated the endotoxin release. You can see when you have given the 10 power 12 high doses in the early infection, you can see there is sudden increase in the interleukins. And then endotoxin also, if you are giving, the endotoxin is getting released more when you are giving the higher doses at the early stage of the infection. And in the 10 power 5, you can see PFU per ml, there was the rise, but it has came down and it remained lower. So it shows that the this 10 power 5 PFU per ml may be safer, and it can be used in the human being at the different intervals. So what they say, they have also opened the Center of Innovative Fast Therapy and Therapeutic at the University of California, San Diego, the first dedicated fast therapy center in North America. Part of their mission is to persuade people of the urgency of finding a solution to antibiotic resistance. Unless sometimes something is done, Stephanie says one person will be dying of superbug infection every 3 seconds by 2050. So you see this red fonted letter. This is why we started in India earlier, and I am not boasting, but I would say that we are the only clinical people who are doing these experiments in the animal as well as the human model, and we hope that the whole country is one day accepting this modality of the treatment, and we can save thousands of the life. So, but to be honest, what Stephanie says, I was extremely embarrassed because I was really blind to this global threat, the superbug crisis that had crept up on me. So superbug is coming out. This is being used in the poultry, in the aquaculture system, fishery, and the you see animal husbandry. A lot of their antibiotics are in soil. So all these bacteria, and you know the concept of One Health. So those bacteria are coming to the human by just creeping in through food and water to us, and they are causing problem if the immunity has gone down by due to certain region, maybe local or maybe systemic, and they are causing the serious infection to us. So after the interesting story created by Stephanie, the study, we have seen that the bacteriophage therapy can prevent, and before that we have started the bacteriophage therapy in septicemia since 2005, and we have conducted on Pseudomonas aeruginosa, and then after that Acinetobacter baumannii, and we have recently completed the Klebsiella pneumoniae septicemia just to decide what should be the optimum dose. So what we did is just we decided the LD 100 by giving different doses, but I shall be showing you some of the limited slides. So first slide I shall be showing you that we got that this dose 8 into 10 power 7 CFU per ml, if given in the dose of 100 microliter intraperitoneally, this led uh, to the death of the mice within 48 hours. You can see here. So all of them died. So it means we have started from the smaller dose in power 3, 4, 5, then 7. We found that this is leading the death to, and in 48 hours, all the mice. So we took this LD 100 and then we started experimenting with the smaller doses of the bacteriophage cocktail, that was 10 power 3 per ml, 100 microliter. And first time we gave along with the bacterial this challenge, that is simultaneous dose, and let us see what happened. So you can see here 10 power 3, here this mice is looking a bit sick, and then if you just we did the recording 24 hours after, and we can see the result here. This is simultaneous. These two are looking very sick, and then this 10 power 3 PFU per ml, there is death. These two are going to die it seems, and 3 will be surviving. And then ultimately after 96 hours you can see that 3 are surviving, rest died. So 10 power 3 is not giving the full production, 40% of them are dying. So then we started doing the testing, the 10 power 4 PFU per ml, and we gave the this productive challenge 6 hours after the bacterial challenge, and you can see this video has been recorded 12 hours later, the after the bacteriophage challenge, and you can see they are looking sick. And then this video is 24 hours later prepared after 10 power 4 dose. Again they are looking sick. And then this is 72 hours later, 10 power 4 dose, and you can see they are still looking sick, and one has no, there are all five, but they are looking sick. Let us see what is happening next. So still they are not recovered, they are looking sick. It means this dose is not giving the protection, and one of them died here. Here you can see. So 20% mortality is there. So 10 power 4 is not looking satisfactory. Then we started the treatment with the other this one, and then we started the therapy with the dose of higher dose, that was 10 power 3, 10 power 4, and now we started 10 power 12, and then we gave 6 hours after the bacterial challenge, where we found that there was death after giving 10 power 4. So let us see this high dose of the bacteriophages what they are doing. So here you can see the recording has been done 12 hours after the bacterial challenge. They are sick, and then here in this case we have this is 24 hours after the 10 power 12. and they are still sick, but it seems that there is no death. The third video after 72 hours, and you can see there is death. So 10 power 12, when you gave the higher dose, that is not protective. Neither the smaller dose was effective or protective, nor the high dose when given around 6 hours of the infection. So that was the story. Then we decided to optimize the dose. So we have seen that 10 power 2, 10 power 3, 10 power 4 and 10 power 12 PFU per ml of the bacteriophage count was not protecting. And our previous experience with the Pseudomonas aeruginosa, we could see that the around 6 hours the higher doses were killing the mice. Yeah, if the bacteriophage higher dose was given initial 6 hours. And in Acinetobacter baumannii, we found that if the doses are small, so there was death after 24 hours of the bacterial challenge. So therefore we shifted to the 10 power 5 PFU per ml, and then that was the bacterial challenge was given 6 hours after the bacterial challenge, and this video has been prepared 12 hours later, the after the bacteriophage given to this one. And this is again a 24-hour after, sorry. So you can see this video, they are quite well, looking good. And then you can see this is 48 hours after this one, there is no death. And then again, if you see after 72 hours, this dose given, there was no death. They are all playful, so they recovered. So this 10 power 2, 3 and 4 were not protecting. 10 power 12 was also not protecting given at within 6 hours of the bacterial challenge, but 10 power 5 was protecting. So this is very important. And then if you see the when we give the bacteriophage cocktail 6 hours before the bacterial challenge, here the same thing what happened means as a prophylaxis we gave, and you can see this video has been prepared 12 hours later. And then next video is after 12 hours, no death. Then 24 hours later this video has been prepared, and they are all playful, they have recovered, no problem, no death. And then this is 72 hours after the bacterial challenge, and there is no death. So this is interesting, 6 hours before, 6 hours later, 10 power 5 per ml bacteriophage count was quite protective, and there was 100% protection. So we then took the another experiment when we gave the bacterial challenge first, and then 12 hours later we started the bacteriophage therapy, this one. So this video has been prepared 12 hours after the bacterial challenge, and let us see what is happening. So they are looking sick. This is 24 hours after the bacterial challenge. Bacteriophage therapy given, is still sick because 12-hour duration is a bit longer. That's why the recovery is slow with the same dose. There seems to be a recovery. There is no death at all. And then after 72 hours, you can see there is no death. So this is the story with the, it means before and after there is protection with this dose 10 power 5. So next we have given the, sorry. Hello? So it seems that 10 power 5 dose is protecting when given simultaneously, when given 6 hours before and when given 6 hours later, and also 12 hours later. And I'm not showing that video. When given 24 hours after the bacterial challenge, then again there was protection by 10 power 5. And you see, if we are not giving these doses, and with the 8 into 10 power 7 bacterial count, CFU per ml bacterial count was killing all the 5 mice. 10 power 5 was protecting when given simultaneous, when given 6 hours before, when given 6 hours later, when given 12 hours later, and when given 24 hours later to the bacterial challenge, what was protecting. So it could be concluded that the bacteriophages dose should be optimized, and if needed in human population, if you are going to translate this animal experimentation, we should take care that we may give the smaller repeated doses with the monitoring of the patient's condition like blood pressure and the oxygen concentration, as we are doing in the corona. And we can repeat the doses because human population we have got a lot of system by which we can monitor, while in mice we cannot do it. So it means the medium dose, neither the smaller doses nor the largest doses are 100% protective. Optimum dose of bacteriophage cocktail can protect the patients from dying out of the drug resistant bacterial septicemia. So this fourth part of my lecture could show that with the continuous 15 years of our experiment, that 10 power 5 PFU per ml given in repeated doses with the monitoring of the vitals of the patients might be successful. So this is all about the bacteriophage therapy and septicemia model, which till date we have done. We are still working on the UTI model and the pneumonia model. So with this, thank you so much.